professional skills. And now you're fourth year students. Congratulations on making it this far, and I wish you all the best. So for today, we'll be talking about pancreatitis and peptic ulcer disease. We will start with the pancreatitis. I hope that the lectures will be short for you, since you guys had a long day lecturing. So I'll be talking about the high yield information about the type of pancreatitis, whether acute, chronic, and the complications, okay? And for peptic ulcer disease also, we will go on the types as well, whether gastric ulcer or duodenal ulcer, and how to differentiate between them. So I'm not sure how you guys are studying for surgery in general. AMBUS. That's really good. Good. So I think by now you're in the fourth week, right?
Yes.
Of surgery block.
Fifth.
Okay, nice. So at least you recognized like how are we studying for the clinical topics. So first we go through the definition. So we define the condition, we go back to the causes, and then clinical presentation and how to differentiate it between other manifestations like the differential diagnosis, and then we go on the investigations and management, okay? So, and of course, like these topics are dealt with internal medicine and surgery, okay? Usually the surgical treatment comes at the last part of the management, because usually we go into the medical treatment, and if medical treatment fails, then we go into surgery, okay? So you have to appreciate that pattern. So for acute, so we'll start with acute pancreatitis, okay? So I'm really sure that you guys are familiar with acute pancreatitis. So you took it in third year as well, right? So any idea about what's going on in the acute pancreatitis? How can you define that? Nice. So technically it's auto-digestion of the pancreatic tissue by the enzymes that's released by the pancreas itself, okay? And if we go into the histology, you guys are familiar with the inactive enzymes and the active enzymes. So what do we call the inactive enzymes? Yes, the proenzymes. So normally, and within the pancreatic tissue, we have the SNR cells, okay? The SNR cells are the cells responsible for the production and the storage of the pancreatic enzymes, right? And they are usually stored in the inactive form, which is the proenzyme, okay? We have something that activates these enzymes into the actual enzyme. So if we are talking about the pancreatic enzymes, what does it activate? Yes, so we have the acid that's coming from the stomach. We have also the trypsin. So trypsin is the enzyme of the pancreas, okay? But which enzyme activates trypsin? Trypsinogen is the inactive.
Enterokinases.
Yes, enterokinases. Perfect. So enterokinases are the enzymes that's coming from the small intestine. It's not there in the pancreatic tissue, okay? So if there is something going on, like something from the lumen, from the intestinal lumen that goes into the pancreas, which activates the trypsin, trypsin usually digests the proteins, right? So here we will have the auto-digestion of the pancreatic tissue. And we will see why is this happening. So, as we said, the trypsin gets activated by the enterokinases, and the trypsin by itself activates the other proenzymes like phospholipases, elastases, and lipase. Okay. So here's the first pathway of this activation. So we have something called pancreatic duct obstruction. As you guys know, the pancreatic duct has the main pancreatic duct and the accessory one. Yes. So if we have an obstruction, there would be intraductal pressure buildup, okay? And the pancreatic enzymes will be accumulating, and then the accumulation by itself could activate these lytic enzymes and cause erosion, and like these enzymes are corrosive in nature, okay? So we will have this massive activation of these enzymes. The activation of the enzymes will activate the inflammation process, okay? So we will have cytokine release, okay? And in general, what does these like cytokine release do? Inflammation, but how? Nice. So first, if we are talking about the bigger picture, we have the blood vessels, okay? So these cytokines could increase the permeability of these vessels, okay? Increasing permeability will also goes into the blood vessels, and we will have a massive loss of fluid, okay? So this massive loss of fluid will impair also the blood flow to the SNR cells, okay? Impairing or decreased blood flow to the SNR cells will also make these cells defective, okay? So they will be prone to the release of more proenzymes, and these proenzymes will get activated more and more. So we are creating a vicious cycle, okay? And also the impairment of blood flow by itself will lead to as I said, the loss of SNR cells and the autodigestion, okay? So this is the first one, the ischemic injury to SNR cells. The second thing, so primary SNR cellular injury, and this is caused by direct toxins, okay? So what are these toxins? Alcohol, smoking, trauma, maybe, okay? So all of these are considered direct injury, okay? And also will lead to the activation of these enzymes. The third one is the defective intracellular transport of proenzymes, okay? So we will have the proenzymes coming together, which also lead to the cascade of activation. Okay, so this is a mnemonic that's good to understand the causes of the pancreas. So we have something called idiopathic. So do you guys know what's idiopathic?
Unknown.
Yes, unknown cause, okay? And actually it constitutes 20% of the cases of pancreatitis. The most common cause globally is the gallstones, okay? The second most common is the alcohol. But if we're talking about the US, there it's alcohol is the most common cause, okay? And also we have drugs like steroids, also valproic acid and all of these stuff. But it's not important to focus on the names of the drugs, okay? Also we have some infectious diseases like mumps, CMV, so we'll go through these. So first is the gallstones. As I said, it's the most common cause. And how is it leading to pancreatitis? So we have here, if you can see the cursor. Yes. So here we have the gallbladder and then the common bile duct, okay? The common bile duct are connected with the main pancreatic duct through the ampulla vater. Okay? So if we have these stones coming from the gallbladder into the common bile duct, then obstructing the ampulla. Okay? So we will have a buildup of the pancreatic enzymes in the pancreas, and this will lead to the activation of these enzymes. Okay? And also, it can lead to bile acid reflux into the pancreatic duct. Okay? And this is where the enterokinases are coming. And also, if we have these stones, usually the ampulla vater is closed. Okay? But if we have it, it could dilate that canal and will lead to entering of the enterokinases into the pancreas. Okay? You're following? Okay, so the second most common cause is alcohol, and it's related to direct injury to SNR cells. As you know, the alcohol contains acetaldehyde, which causes the increasing of the permeability of the SNR cells. Okay, if we have increasing in permeability, these cells will release what's stored in it. Okay, and also it can lead to increased pancreatic duct pressure. And the third one is the iatrogenic. What's iatrogenic? So it's done by medical intervention. Okay, so usually any surgery that can manipulate with the gastric tract can lead to pancreatitis. Okay, but the most common one is the ERCP. What ERCP means? Perfect. So endoscopic retrograde cholangiopancreatography, which is an endoscopy that goes through the mouth into the duodenum, and then from the duodenum into the ampulla vater to explore the pancreatic duct and the CBD. Okay. The third, another cause is the metabolic. Okay. One of the metabolic is the hyperlipidemia. So hyperlipidemia by itself can cause pancreatitis, but in a condition that the serum level of triglyceride should be above 1,000 milligram per deciliter. So if it was below 1,000 milligram per deciliter, we shouldn't consider it as a cause of pancreatitis. Okay? And this is usually seen in type 1 and type 5 hyperlipidemia, but you shouldn't care about the types of hyperlipidemia for the time being. Another cause is the hypercalcemia. Okay? So hypercalcemia is also involved in the activation of the pancreatic enzymes. And usually also the parathyroid hormone is directly associated with the activation of these enzymes. Okay? As I said, one of the causes of pancreatitis could be infectious, as in mumps, Coxsackie B, and CMV, etc. So, what do you see in this picture? Yes, so parotitis, okay? This is one of the manifestations of mumps. And here are the drugs. As I said, you don't have to focus on the names, but usually, like most of the drugs, if it was on high doses, it could cause acute pancreatitis. And also we have a vascular cause, which could be like severe hypertension. The idea of it is that there would be decreased blood flow to the SNR cells and lead to ischemic injury. And also we have autoimmune diseases like systemic vasculitis, SLE, rheumatoid arthritis, etc. And it could be also associated with tumors. Like if we have a tumor in the head of pancreas, there would be obstruction of the pancreatic duct, and it will activate these pancreatic enzymes. And also we have congenital cause. It could be the pancreatic divism. So we talked about the pancreatic duct, and it contains the main duct and the accessory one. So the divisum is the abnormal formation of these ducts. Okay, so if you can see the cursor, this should be the ventral duct, should be the main duct. Okay, but here in the pancreatic divisum, it's much less than the dorsal duct, which is the dominant here. But normally it should be the opposite. Okay, so they are L formed. That's why it could be prone to any injury. Okay, so if one of the patients have pancreatic divisum and had a little amount of alcohol, it could exacerbate this abnormality and lead to acute pancreatitis. So here's the most important thing. So from the message from the previous slides is mainly about three things. So the most common cause of acute pancreatitis is gallstones. The second one is alcohol, and 20% of the cases could be iatrogenic. That's the whole message of the previous slides. Now we're coming to the important part. Okay, so the clinical presentation. Typically, the clinical picture of the pancreatitis could be a sharp epigastric pain which is radiating to the back. Okay, and the most important thing is that it's improving with leaning forward. And what's the point of that? So why is it improving while leaning forward? Any idea? So think about it. Like on top of the pancreas, we have the small intestines, we have part of the stomach. So all of this is building a pressure on the pancreas. So if the pancreatic tissue is inflamed, any pressure will lead to very sharp pain. Okay? So while leaning forward, you're releasing the pressure from the pancreas. So it will lead to improvement of the pain. And this is very important, and most of the board questions are focusing on this point. Okay? So other symptoms could be nausea, vomiting, anorexia, and also ileus, which is the functional obstruction or functional paralysis of the intestines, and fever. Okay. And so we said this is the typical picture. However, 15 to 20% of the patients only have this pain. Okay, while 80% they do not present with such pain. And there would be also a severe type of pancreatitis, which usually defined as acute pancreatitis plus involvement of other organ. Okay, so if we are talking about systemic symptoms or systemic organs, it would lead to autonomic dysfunction. Okay, autonomic dysfunction means that the patient is going to present with tachycardia, hypotension, oliguria, because usually it leads to renal dysfunction as well. Okay, and generalized tenderness, along with absent bowel sound, which goes with ileus. Okay? Do you know what's ileus? Did you take it or not yet? Okay. Okay. So and then we have the advanced necrotizing pancreatitis. Okay. This is usually goes with the severe type of pancreatitis, and it involves perforation and bleeding in the peritoneum. Okay, so we will have something called periumbilical bruising, which is colon sign. We will have a picture about it, and a flank bruising, which is called a gray Turner sign. Okay, so this is colon, this is periumbilical bruising. So what does it signify? I mean, like, if you see this picture, it tells you that there is a bleeding, okay? So it's bleeding within the peritoneum, okay? While gray Turner sign, it's the retroperitoneal bleeding, okay? And also it could lead to jaundice, cholangitis, and shock. So why it could lead to jaundice? Perfect. So if there's an obstruction, it could lead to buildup of the bile and the CBD, and then you will have stasis, which leads to inflammation of the CBD, which is called cholangitis, and the manifestation of the cholangitis, which is one of them is jaundice. Okay, and shock, as we said here, tachycardia, hypertension, oliguria. This all signifies shock. Okay, so now we're done with the clinical manifestation. We're coming to the investigations. How can we diagnose the acute pancreatitis? So we have three things. So you can depend, in most of the cases, on the clinical picture, and you have some blood tests and the imaging. Okay, so when we are talking about the blood investigations, and the pancreatic enzymes usually have amylase and lipase. Okay, amylase is sensitive in terms that it can tell you that there is abnormality in the pancreas. However, it's not that specific, and we will see why. So usually it rises in the first 24 hours after the onset of pancreatitis, and then it goes back to normal after 3 to 5 days. Okay, while on the other hand, the lipase has a much longer half-life, which stays for 14 days approximately. Okay, and then it can be elevated like after 4 hours of the onset of pancreatitis. Okay, so and also the amylase is being produced by other organs. Okay, like in the mouth we have the salivary glands, which secretes amylase. Okay, however, the lipase is only being secreted by the pancreas, so it's more specific than the amylase. Okay, and usually, like if we saw the elevation of amylase and lipase, does it signify that there is pancreatitis? So do we have a criteria to depend on? What's the criteria? So if we have the amylase and lipase are above normal, does it signify there is pancreatitis?
No.
Perfect. So it has to be a 3-time upper normal limit in order to consider the diagnosis of acute pancreatitis. So if it was lower than three times upper normal, then this is not the level of pancreatitis. Okay? So here you can see the other causes of elevated amylase, which we are not focusing on. Other investigations, like the C-reactive protein, CRP, which is an inflammatory marker used for evaluation of the severity and prognosis of pancreatitis. And we can also run other investigations, and that's usually to monitor the level of hydration after the incidence of acute pancreatitis. So as we said that the the inflammatory process in the pancreatitis is very heavy and remarkable in terms of we have increased permeability in the vascular bed, okay? Increasing permeability meaning that most of the blood content is going out of the blood vessels, okay? So we will have the patient is suffering from dehydration, hypertension, tachycardia, oliguria, and all of this stuff. So as we will see, the mainstay of the management would be depending on the rehydration of the patient, okay? So it's very important to to monitor these other things like the CBC, the electrolytes, the level of albumin is very important as well. Okay, so if we are talking about the imaging, we have the chest X-ray and other than that, but the most important thing, which is the CT scan with contrast. So this is the modality of choice, but not on all cases. So for instance, a patient is, I'll give you a clinical vignette and you tell me which imaging modality that we can best go for. So let's say that a patient is having right upper quadrant pain, okay? And this is usually radiating to the right shoulder, okay? And also the patient is suffering from nausea and vomiting, okay? So which imaging modality is best to select? Why? Perfect. And as we said, the most common cause of pancreatitis is gallstones, okay? So in case of gallstones, if we are suspecting gallstones, the modality of choice would be ultrasound, okay? Other causes, we can do a CT scan with contrast. So here could be the findings on the CT scan, okay? As we said, we have severity as well of acute pancreatitis. So in the mild pancreatitis, you can see the pancreatic tissue edematous. There is peripancreatic fluid, but the most the most characteristic or the most significant finding on the CT is the enhancement of the pancreatic tissue. So you would see the pancreas brighter than any other tissue. Also, you can see signs of hemorrhage and necrosis. So what are the signs of necrosis? Any idea? Saponification, okay, which is calcification. Perfect. And
Wall cancer, occurs because of speed.
okay, this is necrosis. What else? We have air fluid levels or gas bubble, okay? So here are the, this is the pancreas. As you can see that there is enhancement of the pancreatic tissue. So it's brighter than the liver, okay? And you can see also a layer around the pancreas, okay? Which is the peripancreatic fluid, which is the interstitial edema. And you can also see necrosis, which is also visible here. So this is necrotic fat around the pancreas. So for the diagnosis, we talked about the clinical picture, which is epigastric pain radiating to the back. We also mentioned the amylase and lipase, and we said that it should be 3 times upper normal in order to consider the lipase and amylase as a sign of pancreatitis. And we talked about the radiology, which could be ultrasound in case of gallstones and CT, okay? So if we have 2 of these findings, so let's say the patient is suffering from epigastric pain radiating to the back, we ran the lab and we said we saw that the amylase and lipase are going above 3 times upper normal, then we don't have to do any imaging modality in order to diagnose the patient as acute pancreatitis. Okay, so 2 of these 3 are enough. So always remember that. Okay. And there are also like some sort of assessment for severity, but this is not very important actually. So if we're talking about the Ranson's criteria, this is just to give you an idea about the severity of the cases. Okay, so they're giving points on the positive signs. Okay, so if you collect these positive signs on that scale, you would see the percentage of the mortality. Okay. This is also an index related to the findings on the CT, but that's not important for you guys. Okay, for the treatment, we said that the mainstay of the treatment is to keep the patient on rehydration. Okay, so we need to keep the patient NPO. What's NPO?
Non-per-oral.
Very good. And why is that?
To not activate the lipase.
Perfect. So we don't want to activate or stimulate the gut to produce more enzymes. Okay? And sometimes they use also nasogastric tube in order for to do decompression. Okay? And they treat with aggressive fluid replacement. And usually, like, the fluid replacement is about 4 liters in the first in the first 2 hours. Okay. And usually, like, it requires 10 to 12 liters of fluid replacement. Okay, so this is really massive. And in the first hours of the fluid replacement, they don't go very aggressive. Why is that? Because they want to make the albumin level at the normal. Because hypoalbuminemia also will do hypertriglyceridemia, which could attribute to pancreatitis later on. Okay, and also they insert Foley catheter in order to see the urine output, which is also a sign, like, in order to monitor the rehydration. Okay. Usually they don't go into prophylactic antibiotics unless there is signs of infection and necrosis. Okay. Otherwise, no role for antibiotic in the treatment. And actually, the acute pancreatitis could be very painful. And here comes the analgesic role. And sometimes the patient even addict painkillers. Okay. Feeding could be enteral once the patient is recovering, which is usually after the day 3 of acute pancreatitis. Okay, usually patients recover during 5 days. So early feeding through parenteral, that's fine. Okay, and of course, like in case of very critical cases, they need to go into the ICU and they monitor them closely. So this is a slide about the rehydration. The home message of this is that in most surgical cases they depend on crystalloid fluids, and usually they prefer lactate, Ringer lactate over normal saline. Okay. Now let's talk about the complications of the acute pancreatitis. So we have something called pancreatic ascites. Okay. We have also pancreatic pseudocyst. So we will talk about the important ones. Okay. So first, we also have systemic manifestations or complications. One of them is the pleural effusion. And why is this happening? So as we said, in the advanced acute pancreatitis, the cytokines are massive, that it could lead to like blood, like the vascular permeability. Okay, vascular permeability has these cytokines in the serum. It goes to the pulmonary tissue and destroy it. Okay, that's why we have this pleural effusion. Plus, we have the direct insight, which is coming from the pancreatic tissue by itself. It could cross the diaphragm and goes to the pleural space. Okay, and it causes also a damage and pleural effusion. Okay, and it could lead to acute respiratory distress syndrome. So the first complication is the pancreatic ascites. We have it due to leakage of the pseudocyst itself. So we have something called a pseudocyst. What's pseudocyst? Yes. So it's a fluid collection formed by a fibrous capsule, but it's not a true cyst, because the true cyst usually is lined by epithelial cells or epithelial tissue. But this is not lined by epithelial tissue, it's just like a necrotic tissue, fibrosed, and has all the digestive enzymes and some tissue debris over there. Okay? So the ascites, 70% of the cases are coming from the rupture or leakage of the fluid from the pseudocysts, and it could come from the pancreatic duct. Okay? And this is more common with the alcoholic pancreatitis rather than any other cause. And it also could be associated with pleural effusion, as we said. So, do you know how to analyze the pancreatic or the fluid of the ascites? What are the markers? 3.5 Okay. So what's that 3.5 protein?
It's more than, I think, 6 a day, and less than 600. That's
Nice, very good. So for the pancreatic fluid, what's the color? Do you remember?
No.
So in terms of pancreatic ascites, usually it's milky. Okay, and okay, that's enough for you. The next one is the pancreatic pseudocyst. Okay, as we said, it's not a true epithelial lining. It's a cavity surrounded by fibrotic tissue, and it's the most common complication of pancreatitis, and usually it happens after 2 to 3 weeks of the initial attack. Okay. The location is important when it comes to the symptoms of the pancreatic pseudocyst. So how does it present? So the main point on the presentation is that the pseudocyst could do an obstruction. Okay, so mainly it's in the lesser sac on the stomach. So that area has the duodenum, the stomach as well. So it could lead to gastric outlet obstruction, jaundice if it's obstructing the CVD. Okay, and it could lead to left pleural effusion. And why left, to be specific, if you guys remember? Because the left diaphragm is weaker than the right diaphragm. Okay, and if it's as you know, guys, the digestive enzymes are corrosive in nature. Okay, so if it's coming nearby the splenic vein, it could lead to aneurysm of these veins or portal veins. Okay, and it could lead to aneurysm and thrombosis later on. Okay, so the presentation is all about a mass that's producing symptoms and obstruction. So the mass usually presents with persistent pain, fullness, which is by early satiety, because if there's gastric outlet obstruction, then if you are eating, the food is not going, okay? So you will feel full, okay? And usually it involves nausea and vomiting. So how to diagnose the pseudocyst? The answer is by CT scan, okay? And usually the ERCP is involving the management, okay? However, not all the pseudocysts are being treated surgically or by intervention. So if they are asymptomatic or less than 5 centimeter, you only need to have to do supportive treatment, which is similar to the treatment of the acute pancreatitis, okay? However, if it's massive and producing symptoms, then it needs to be drained by endoscopy, okay? The ERCP. And these are the indications of drainage, which is if the pseudocysts are increasing in size, symptomatic, there is some sort of GI obstruction, etc. And the pseudocysts are associated with malignancy. So if there is endoscopy, then it has to be biopsied, okay? You don't have to know this drainage procedure. The only thing you have to know is when to intervene, okay? So if it's producing symptoms, if it was more than 5 centimeter. And this is the CT scan. As you can see that this is the cyst, and these are the calcifications, okay? So probably this is chronic pancreatitis or necrotizing pancreatitis. The pancreatic abscess, if this pseudocyst is infected, okay? So it's producing infection, and if there is infection on top of necrosed tissue, okay? The presentation usually with any infection is fever, elevated WBC, abdominal mass, etc. Okay, and the investigation also CT scan, which, as we said, the abscess usually involves also like if it's there necrosis, then you can see air fluid levels. Okay, the treatment usually if it's necrosed, then it has to be drained endoscopically. Okay, and you would need to treat the infection with antibiotics. Necrotizing pancreatitis. So it could also happen in the absence of infection, which is called sterile necrosis, and it's associated with secondary infections, as we said. Okay, and usually also like the mainstay of treatment is conservative. However, in some cases we need to do surgery in order to remove this necrotizing necrotizing tissue. And why is that? Because it's becoming a site for forming infections. Okay, so when do you have to do surgery? If there is symptoms, which is acute abdomen. So what's acute abdomen? Any idea?
Acute pain to the abdomen comes abdominal burning and possibly bowel symptoms.
Perfect. So it's sudden severe abdominal pain, and usually like it's all over the abdomen, and it involves signs of peritonitis. So again, what are the signs of peritonitis? Guarding, rigidity, so all of this. If there is sepsis, that's coming after the infection of the necrotized tissue, and if the necrosis is like forming more than 50% of the pancreas itself. So these are the air fluid levels or the gas bubbles. So, as we said, the treatment of necrotizing pancreatitis, if it involves, we said previously about the antibiotics. So we should give antibiotics if there is a sign of infection or necrosis, okay? Otherwise, we don't treat acute pancreatitis with antibiotics. And we need to remove the necrotic tissue if it's producing these acute abdomen infection or gastric obstruction. So one of the complications of the pancreas is if it involves the vessels, okay? Like if there is corrosiveness on the adjacent vessels, then it can produce hemorrhage. And we saw the signs, which is colon and Gray Turner sign, okay? So if there is hemorrhage, the treatment is surgical intervention in order to stop the bleeding of the involved blood vessels. Now, let's talk about the chronic pancreatitis. So the chronic pancreatitis, usually it's more with the alcohol, okay? And the acute or moderate drinking of alcohol is not associated with chronic pancreatitis. However, it involves drinking alcohol on the long run, okay? And usually for males to develop chronic pancreatitis, it's 18 years of drinking alcohol, and for females it's 11, okay? And it's not associated with moderate drinking or binge drinking. Other causes could be hereditary, like autosomal dominant, hyperparathyroidism, as we said, and malnutrition, okay? So we're not focusing here on the causes. The clinical presentation, as opposed to the acute pancreatitis, which usually involves severe epigastric pain, this could be constant and dull, okay? And also radiates to the back. And this involves the chronic pancreatitis. The pathogenesis involves continuous inflammation, okay? So in the pancreas itself, due to multiple inflammation process, we are developing fibrotic tissues, okay? So the bile or the pancreatic duct will be we will see later, it's involving obstructions all along the pancreatic duct, okay? So these obstructions would also lead to activation of inflammation process, okay? So it worsens after food or alcohol consumption. And why is that? Because when we eat food, we are stimulating the gut to produce more enzymes, okay? And alcohol is the direct toxin. And usually it's associated with pseudocysts, okay? Another manifestation of chronic pancreatitis, other than the dull pain, is the malabsorption. And why is that? Because the pancreatitis is like an exocrine gland and endocrine gland, okay? These enzymes are essential for fat-soluble vitamins, okay? So if we are losing the exocrine gland, then we have malabsorption, okay? And we have to replace these enzymes of the pancreas in order for the patient to recover from malnutrition. And also there is endocrine insufficiency. The pancreas is producing insulin, so patients will be developing diabetes mellitus, okay? And also, as we are replacing the enzymes, we are replacing insulin as well. On imaging, you can see the calcifications through plain X-ray, and also you can see it on CT scan, as we saw before. Okay? And also you can diagnose the chronic pancreatitis with ERCP. So here we talked about the fibrosis around the pancreatic duct and how it appears on the ERCP. Okay? So there are like stenosis all along the pancreatic duct. The treatment is to stop consuming alcohol, which is the most common cause, and we do stenting of the pancreatic duct in order to release the stenosis. Okay, releasing stenosis would attribute to less inflammation. And also for malabsorption, as we said, we are replacing the enzymes. It could lead to also biliary obstruction, and the treatment is that we do also stenting of the CBD in order to release this obstruction. Okay, so when do we have to do surgery for chronic pancreatitis? So the treatment usually for chronic pancreatitis is involving pain and because it could be constant dull pain, okay, which could affect the quality of life of the patients, okay. So this pain would lead to like narcotic addiction of the pain medications. So if it goes to that level, then we have to do surgery, okay? And surgery usually involves the removal of the pancreatic tissue. So since it's not functioning anyways, we're replacing the exocrine enzymes and the insulin. We may remove the pancreatic tissue as well, okay? So removing the pancreatic tissue would relieve the pain of the patient, usually in 50 to 90% of cases, okay? So in the next slides, this is all about the surgical interventions that involves removing the pancreatic tissue. This is a procedure called pesto, okay, which involves having the jejunum directly anastomosed to the pancreas in order to release the pancreatic duct from the stenosis around it, okay? So we're resecting the pancreatic tissue and salvaging the pancreatic duct with the jejunum. But you don't have to know about the details of these surgical. Yes, so this is jejunostomy. So we're bypassing the duodenum. And why is that? Because the duodenum has the ampulla of Vater. So even like if we have the if it involves the necrosis or the fibrosis of the head of pancreas, we could have also that part to be obstructed, okay? So we do this bypass to relieve the obstruction from the head of pancreas. But you don't have to know about all the details of these interventions, okay? So that's it for the pancreas